There. Hi, Dr. Fasullo.
Hey, Dr. Young.
Thanks for meeting me on the internet.
Love to be here.
Yep. Just making sure we're good as we go forward tonight. We are meeting tonight to chat about all things. Yeah, we're good to go. We're here to chat about all things heart health. Exactly. Love it. Just for people who haven't gotten to meet with Dr. Fasullo and I, we're both naturopathic physicians who practice in Manchester, Connecticut. And Dr. Fasullo is particularly great at all the nuances when it comes to cardiac health and prevention. So we're chatting about all that stuff today. Hopefully giving you guys some take homes for what to do to help make sure you're in the best place possible cardiovascularly. I'm getting a little bit of feedback on my end. Let me know if you are on yours.
I'm okay right now.
So take it away, Dr. Fasullo. What do you think? So a person comes into your office and they have a very extensive history of cardiovascular disease in their family, and they want to do everything right. Let's talk about maybe screening tools that you use with them.
Yeah, that sounds great. I appreciate doing this the day after Valentine's Day. Sorry, I'm just trying to manipulate the camera here. Find the center. Here we go. So, the heart means a lot of things to a lot of people, and we celebrated all the love yesterday, and now we're going to talk about how to keep that love pumping through our bodies and our vessels and stay healthy. So, yeah, people come into me for a lot of reasons. Not infrequently, it's because personal history of high cholesterol or family history of high cholesterol or heart disease, and trying to be a little bit more preventative. So, typically people will come in with a cholesterol panel. All right, so everyone's familiar, I think, of all the numbers in all of medicine.
Right?
Most people know one number. Yeah. What number, Dr. Young?
All right. Yeah. That. Which one's the good cholesterol? The good one or the bad one? Yeah.
So everyone knows their total cholesterol number. So it turns out that in the scheme of things, that's kind of the least important number of all the numbers, but it's the one we know because it's been drilled into our head. So we have this notion that if it's above 200, that's bad. And if it's below 200, that's good. And that is an oversimplification on top of oversimplifications. And so what we try to do is start to tease it out. So again, people come in for a lot of reasons, but they're looking for a different perspective or a natural alternative. But the first thing we do is not recommend the natural treatment for cholesterol. It's get more information, right? So that's the whole thing. Get more information. There's so much more out there that we can learn about not just what our cholesterol is, but how healthy our heart is and what our cardiovascular risk is that's available and affordable out in the world. And then when we have all that information, then we can start making better decisions about what we're going to do about it.
Absolutely. So I think, do you want to mute me for a second when I talk on your end? That way I don't feedback. Can you do that? If not, it's cool. I'm not going to be able to talk as much with you so that we don't have too much feedback. Did you mute me? No, I muted you. But it seems okay. So when I talk, you want to mute me. So, I mean, like we said before, it'd be weird if your doctor was really good at social media, right? That's a weird thing. So it's great that we're learning this.
Media.
We're doing this obviously not because we really wanted to talk about heart health at 5:30 on a Monday night, but because we want to stay connected to our patients and also all the other people that are out there that need to hear about this. So all that to say, you're right. You go to the doctor, you go to your physical, and they screen your cholesterol, and they screen cholesterol because it is one component that goes into making plaque in our blood vessels, right? But it's only one component. And we don't even know, there's some people with very high cholesterols that have no signs of plaque. Mute your bomb and feedback. Okay. So all that to say that if we if we're looking at just cholesterol, it doesn't give us the full picture. So we really want to look at all the aspects of creating plaque, and then how to identify and address the issues that are going on with the person. The cool thing about our medicine is we're trained to look at the person as an individual. So we don't have as much of just your cholesterol is here and you will do fine. It's more of let's look at all the things going on with you and why your family had a roadmap to cholesterol, and let's keep you, to heart disease, and let's avoid that roadmap for you. So I don't know. What are your let's go through some tests and why they're unique. We were talking today when we were like, oh, let's talk about what talking about heart health looks like, and we were like, we probably both have our own little spiels in the office and what we talk to patients about, and we never actually get to hear each other's spiels. So my spiel is this, and then you can throw it back. So we look at cholesterol because it is the component that then gets oxidized and inflamed and gets stuck into blood vessel walls, and then that is going to become a foam cell and create plaque from that piece of things. So because that is one of the building blocks to creating plaque, that's why conventional medicine really wants to monitor it. But also we want to look at those other things, oxidative stress, inflammation, because even if you have a little bit of cholesterol, if you're very inflamed and oxidizing everything, it's going to be a problem. So the numbers that we test when we do our typical lipid panel through conventional labs is just looking at weights. So it's like a Home Depot bucket and how heavy it is. Your total cholesterol weighs this, your good cholesterol, your HDL weighs this, and then we calculate your LDL based off of that. Your bad cholesterol probably weighs about this. And it says nothing about what's in the bucket. And so the testing that we like to do tells us of what's in the bucket, because that's going to make a big difference when it comes to risk factors with cardiovascular disease. That's my spiel. What's your spiel, Dr. Fasullo?
That's good. I like that. I like the Home Depot bucket analogy. That's good. You're a good analogizer.
I am. That's my forte. So
I think what I like to remind people of is that cholesterol is not inherently bad for you, right? Your hormones are made of cholesterol, testosterone, estrogen, progesterone, all these things that are really important for us. Those are made from cholesterol. Our brains are made from cholesterol, right? So cholesterol is not inherently bad. And yes, cholesterol gets laid down in our vessels, but why does it do that? Does it do that because it's trying to give us a heart attack? No, that doesn't make any sense. It's irrational. The body's pretty smart. It's not trying to kill itself, but it's there because it's trying to repair damage, right? So it is all about inflammation. And if you're not checking inflammation markers, then you're really missing the primary boat, because some genetic predispositions for folks are going to be to create more cholesterol, some less. But that's really not as important as A, what kind of cholesterol it is, to speak to what's in the bucket, right? And B, how much inflammation there is that drives that cholesterol to go to the wrong place, right? So, if we break down from that total cholesterol number, which is really unnecessary or not helpful, to the second basic, which most people know, HDL, LDL, good, bad. So HDL, we call it good cholesterol. LDL, we call it bad cholesterol. 50% of people that have heart attacks have normal LDL levels, right? So the standard of care in medicine is to drive the LDL down, down, down. But again, if you're not looking at what kind of LDL it is, what kind of inflammation markers, all your other risk factors, you're still not getting to what the actual information is that we need to make good clinical decisions. Right. Mm-hmm. So I think that's where we start. Cholesterol is not just bad. Let's get more information. So then, speaking of what kind of cholesterol is in there. So if we go HDL good, LDL bad, I think the other important thing to know is that LDL and HDL aren't actually cholesterol, right? They're cholesterol carrying proteins. That's really important to realize too. Cholesterol is like a fatty thing. The blood is like a watery thing. Fat and water don't mix. So we need something to bring it around. So HDL we call good because it brings the cholesterol from your vessels where it's accumulated and brings it back and recycles it out to the liver to get rid of it. Mm-hmm. And the LDL we call bad because it takes it from the liver to the vessels and kind of potentially lays down in the vessel wall. Again, because it's trying to repair damage. It's a Band-Aid. So let's deal with the underlying issue instead of worrying so much about the Band-Aids.
Absolutely. So some big inflammation markers that we look at would be things like, so if you go in and ask your doctor about checking for inflammation, they may not look at the numbers that we're looking at. You know, inflammation in general is this ubiquitous term for your immune system in overdrive, for your system to be irritated by either lifestyle, environmental things, a myriad of causes for inflammation. But there are specific markers for inflammation in blood vessels that we also look at, correct?
Yeah, so there's a number of them, and they can suggest different and varying levels and severity of inflammation. So there's a picture I show people of inflammation in a vessel wall, or plaque accumulation, right? So here it is. There's accumulation of plaque from none, where are we? From none to, oh boy, here we go, to more, right? So there. So the only way we can see what that soft plaque actually looks like is by threading a catheter up through your leg into your heart and looking. So we try not to do that. It's pretty invasive, you know, worst case scenario. But some of those inflammation markers we can check can suggest that there's more or less of that plaque formation happening. And then again, the severity of that plaque formation. So a low risk accumulation versus a higher risk accumulation. So on the lowest end, there are general markers of inflammation, something called C-reactive protein. And then there's one that's more specific for the heart called, surprisingly enough, high sensitivity C-reactive protein. And that gives us just a general sense of systemic inflammation in the body. So that's not really specific to the heart, but we understand that there's inflammation in one place, it's going to affect everywhere else in the body, because it turns out the blood goes everywhere and then comes back to the heart again.
Exactly. So we've had some questions over, like, in general, I can list off a couple other, there are general inflammatory markers that don't necessarily mean that there's something wrong with your cardiovascular system, but it does mean that, like, we want to keep an eye on your cardiovascular system if you have inflammation. So someone asked about, is ferritin a marker of inflammation? Ferritin can reflect your iron stores in your body, but it also at high levels, especially if it's off the Richter scale, is a sign of inflammation for sure. Cardiac CRP is our main one we're talking about, but then there's also ESR, or a SED rate, ANA. These are all other markers that could be signs of inflammation that you want to just be mindful of. Those other ones are non-specific to cardiovascular, but also, yes, correct, that those are markers of inflammation. So yeah, inflammation is something that we need to monitor, because it can tell us, like, are you showing high levels of stuff or not? And I'm always surprised, like, some people have a great lifestyle, but they need some more fine tuning and tweaking because they're still showing up with some inflammatory markers. And then other people, you know, my grandpa was one of them for many years, you know, could get away with a rough lifestyle and did not have a lot of inflammation. So I got some good genes, fortunately. Yeah. So yeah, it's interesting that it's really unique to the individual when it comes to this stuff. And part of that too, when it comes to cardiovascular issues, is how your body responds to the inflammation. Part of it's also the quality of the transport mechanisms, right? So the quality of the LDL and the HDL is something that we also need to look at when we're assessing all of this, because some people, and my grandpa was one of them, had those great genes that were, you know, able to, like, cope with inflammation well, I guess, or whatever. They're predisposed to not creating as much plaque, you know. So you know, one of the markers I know we were talking about that I love testing is lipoprotein A, or LP little a. Do you want to talk about that one? I have all my analogies too, I can throw in later.
Yeah, throw in some analogies. No, so I think when I do these lectures, these cardiovascular lectures for residents and for folks out in the community, and the one thing I really lay heavy on is that everyone should know their LPA level. So lipoprotein A is kind of loosely like LDL. You know, if we think about LDL being the bad cholesterol, and again, there's different kinds of LDL. The smaller, denser LDLs, there's the analogy. There's a good analogy there. Let's do that, and then I'll go to LPA. So talking about LDL and why and how to assess it a little bit further. Everyone, in your cholesterol panel, you know what your total LDL is. It turns out there's some kinds of LDL that are more concerning and some less. So some are bigger, some are smaller. Those smaller LDL particles are the ones that are more concerning, potentially more damaging. So the way I explain it is, if you've got a rug, you got on the carpet, and you throw some tennis balls out on the rug. If you want to pick up those tennis balls, it's easy to do. 1, 2, 3 into the basket they go. If you threw some sand onto the carpet, it's going to get stuck. It's going to get embedded. It's going to be a lot harder to get it out, right? So small LDL particles are like little bits of sand just getting stuck in the carpet, causing more inflammation, more damage. So then if you take one of those little sand particles and you stick some little barbed wire and swords and knives and all little nasty bits all over it, that's like an LPA molecule. They're just real nasty. And it turns out it's a genetically predisposed thing. So you inherit more or less high levels of lipoprotein A, and it's hard to adjust. There's some data, some research suggesting that some things can have some impact, and we talk to individuals about those things. But the most important thing across the board is if your level there is high, it does increase your risk of heart disease over a lifetime, not insignificantly. Mm-hmm. So the most important thing you can do is all the other stuff that you probably should do anyway, but now really should do anyway because it's really important because you have this one risk factor.
Yeah, I agree. Over the years, I've seen a lot of people want to lower their LPA, and I've seen some people do heroics, and we get 5 points down, but everything else looks beautiful. And so I'm the same way. What LPA tells me is that, your cholesterol is more, your LDL is going to be a little stickier, a little more irritating to your blood vessels. And so it's just more important that we watch all these other risk factors. The other one, so we talked about oxidative stress, so I do the same exact analogy, by the way. We must have gotten the ping pong sand one together. But it's basically, so the weight of your Home Depot bucket is the number of LDL. That's the number that we get is a calculation. And then what's in the Home Depot bucket could be ping pong balls or sand. And it can be kind of slimy sand, which is that LPA in my opinion, or it can be less irritating sand. So that just gives us more information about what's getting pushed up against your blood vessel walls. I also run another marker that I look at a lot is, so you look at the inflammation piece of things when it comes to all those inflammatory markers we just talked about with cardiovascular health. But I also look at a couple detox markers or to try to assess if there's oxidative stress or detox support needed. So GGT is a way that the body recycles our major antioxidant in our body, glutathione. And so it's a great way to assess, are we having any risk as far as oxidative stress that way? So if they've actually shown in studies, independent of cholesterol levels, wherever if your GGT is in the top third of the range, that you're more at risk for cardiovascular issues. And so oxidative stress plus inflammation plus cholesterol that may not be optimal, the LDL being not optimal is kind of the piece of it. The other test we can do looking at the quality of LDL is they actually have a test looking at oxidized LDL. Do you run that? I run that at least once on patients to kind of get a gauge on how much are we oxidizing, how much irritation has this LDL experienced where it's potentially going to be an issue for blood vessel walls.
Right. Yeah. I mean, it's really important to look at, right? I mean, oxidation is like rust, right? So if you leave something metal outside in the rain, it's going to rust, and you don't want rusty stuff in your body because it's more damaging, right? So whether we're talking about, food, those advanced glycosylated end products, the stuff if you burn your burger real bad, that's essentially oxidized fats and proteins, which directly cause inflammation. But if there's oxidation on that LDL, that's inherently going to be more inflammatory. So, I mean, it's great looking at GGT, looking at some of these other markers that we don't think of necessarily straightforward as heart markers, but that's the whole point, is that we're not just a heart and some vessels, right? We're not just a bunch of joints. We're not just a brain. We are complex entire creatures. And we deserve to be looked at in that way. And whatever we're talking about, and heart disease arguably the most important because it takes more people every year than anything else, we deserve to be taking a step back and say, well, what's all the information here. So again, so we can make really good educated decisions about long-term health treatment plans and protocols and not, you know, when I tell people, it's a little bit of a, I don't know what it is. What I say is that the heart is amazing and it works really, really well until it doesn't. Mm-hmm. And when it doesn't, that's usually a really big deal. Mm-hmm. So we're trying to get all the information we can to figure out how do we keep it working for longer so mm-hmm. that it doesn't stop working earlier.
Definitely. Yeah. I mean, I was just thinking about, like, if I had to pick my top 3 blood tests to look at cardiovascular disease, would I even put the lipid panel in the top 3? That seems like a little extreme, but I'm not sure. Like, I would probably pick cardiac CRP, LPA. I'd pick some other things over really worrying at how heavy that bucket is. The quality of what's in there and what else is going on in the body is probably more important, you know? So I think it's really, you know, the average physical can test liver function very basically, making sure you're not anemic or have some major blood disorder, and then your cholesterol panel, and then they say you're good. And I just feel like there's so much more to prevention, and that's kind of why we're chatting today, right? Is to look at all these other pieces
about prevention, right? Just because you're not an immediate threat of falling to pieces doesn't mean you're healthy. So if you want to be healthy, you need more information than that. Surprise, surprise, right? The cholesterol panel was cutting edge medicine 30, probably more 40 years ago now. So there's just so much more available that we can do and assess so that we can get more information and make better decisions. I mean, again, and what I tell people is after I do all this whole spiel, we talk about all this and I say, hey, just so you know, just so you remember, there's nothing particularly alternative about anything I said. There's nothing particularly natural, honestly, about anything I said. This is just rational, common sense, thorough medicine. That's what this is.
Speaking of, I guess, like you said, cutting edge and not as natural. One of our favorite tests, you and I, kind of goes in both those categories. The calcium score, I think, is one of the best things that's been coming out of the past. Like, I mean, what has been a better slam dunk? I can't believe insurance companies aren't quite covering it yet, but it's such a great predictor of plaque production and concerns we have for cardiovascular disease. Wouldn't you agree?
I would. I mean, there's so many studies now. It's coming around, and yes, insurance doesn't cover it, but it's available in most places for that $99 flat rate. It's just again a slam dunk. I'll go back to this again. So here's our plaque, right? So this is all soft plaque, and again, you can't see that unless you go thread a catheter up and look. But if we extended this out further, eventually this soft stuff starts to harden and calcify. And that we can see from the outside in this little mini CT scan, very low radiation, single dose, real quick, real easy. And we can assess for what accumulation has been done. So I do these a lot for people that are sort of those middle of the road numbers. They're not terrible. They haven't seen a cardiologist. They're not great. They've been on the fence for a while. Let's do a calcium score. And if you have not built any calcification over your 50 plus years, it doesn't mean you're, you know, all good, right? Again, you can't see the soft plaque, but it's a pretty good assessment. If that middle of the road blood work comes back with a high calcium score, it's a very, very different conversation. So it really allows us to get a sense of where people are in sort of real time. You know, what's flowing through the blood is always changing, but calcification is just there and it's accumulated. And, you know, the cardiologists I know they're doing them like every 5 years. You know, to look for changes over time. So it's not something that gets done regularly because calcification takes a long time, but really informs our decision-making a lot.
I always say it can't be that much radiation because it's only $99 for this test. So CAT scans are usually much more expensive than that. But it's important to so much. And honestly, they can even go down to looking at what blood vessels are damaged if they are showing hard plaque. They can say like, oh yeah, this part of the heart or this artery and that type of thing, which can be so beneficial to knowing the risk. And then, if we see no signs of hard plaque versus we see a lot of plaque, we can kind of make some decisions based off of that. And you're right, that's the hard plaque. That's once it's already kind of laid down and it kind of like the scars on the blood vessels. They usually don't recommend them for under 45 years old, right? I think that's usually what I hear.
Yeah.
All right. And because sure, insurance isn't covering them, but I think most imaging facilities are starting to offer them too, which is nice.
Yeah, they're becoming more accessible for sure.
Um,
I can think over the years, a number of people now with, again, sort of those middle of the road numbers, came back with incredibly high calcium scores, referred immediately to a cardiologist, and,
yeah,
definitely saved some years and some lives that way. Because you just, again, you don't know until you know. And, people, like, the stress test is something people know a lot about. Everyone knows about the stress test. That artery has to be 95 plus, like almost all the way blocked. A little bit of blood getting through is enough. I mean, the body's incredible, right? We can accommodate until we can't. So by the time something comes up on a stress test, that's real far gone. So we're trying to catch stuff way before that. When I see people for this kind of assessment in the office in their, 30s, 40s, 50s, most of these people are not in any risk of having a heart attack tomorrow or next week or next year. But let's make decisions now to avoid those things in a decade and 2 and 3, right? This is truly preventative medicine.
Yeah, which is really nice. Like you said, I've had people who the family history is what prompted it. And, if you had oh, my dad had his first heart attack at age 50, or, all of my uncles have stents. And that's the person that we consider running this on. And it definitely helps you make a decision on whether to do we see a cardiologist? Do we do more of a workup? But I would say at least half a dozen heart attacks prevented because we were on top of it and got those other measures in place. In some cases, some people have had, stents put in and other things that, again, but it's preventing a heart attack, which is awesome, which is what we're aiming for.
Right.
So I think that's one of the slam dunks as far as preventative medicine being also partly educated prevention, is this where we should be putting our focus or somewhere else, that type of thing. So I have a couple people just asking questions. We can kind of do them as we go along. Dr. Fasullo can't see them. I'm the puppet master here tonight. So we do order these tests in the office. Any GP can order these tests. I would say that I usually often use an analogy of to someone's making a reference to just saying the garbage being brought out to the curb is your LDL cholesterol, and how many garbage trucks you have is your HDL cholesterol. So that ratio does make a difference. And then the quality of the garbage in the garbage can is your LPA and the oxidized LDL and that type of thing. How often do you worry about the garbage? So I think those are most of the questions. I'm trying to keep up with, oh goodness, all the stuff coming through. The other thing we didn't talk about yet was soft plaque. So assessing hard plaque, you can look at that awesome, quick, low radiation CAT scan. And yes, most of the doctors here, and honestly, most of the doctors in the community can order this very easily. You do have to have a doctor's order, correct?
Yes.
I think, yeah. So how do you, when you're showing up that great picture, how do you assess soft plaque?
Yeah, so there's some other inflammation markers that are suggestive of some more soft plaque accumulation, right? So there's one called LPPLA2. It's a bunch of letters. LPPLA2. There's another one called MPO, myeloperoxidase. So these are assessments of inflammation, but inflammation driving plaque formation, driving these specific kinds of white blood cells that can accumulate if there's more damage, that increase or suggest more increased risk of rupture of a plaque buildup. So, these are all things that we're assessing over time. So whether it's, every 6 months or once a year or more frequently if we're making changes, it's not exactly where someone is at one point, but how it changes over time. And we can see how our interventions can really affect that change in accumulation. It used to be sort of just thought that, once plaque was there, that's just it. It's just there. It's just going to get worse. But like with most things, it turns out that if you change some things about how you live your life, you can really create some change in how your vessels are affected.
Mm-hmm. I know we're in a neat time where we can really impact a lot of these things. I think there was a lot of it's in my genes. That's kind of how it is. And more we're finding that one, we can identify the genetic SNPs that put you at risk, and also we can do something about it. modifying diet is a piece of it for sure. And I think that like there are a lot of myths about what is good for cholesterol and what's not. That's a whole nother meeting, you and I. But I know, but and there's a lot of supplements too, obviously. But the first thing, I mean, for prevention, and the first thing for people is to empower them with information. So I think that that's definitely a piece of it. We got a quick question about NT-proBNP. We were just talking about that earlier today. Do you want to talk about that real quick? Oh no.
What? I think we lost Dr. Young. I don't know what happened. I don't know if I'm on. I don't know if I'm still on or not. Hey, if you're out there in TV land, can you tell me if you can see me? Testing, testing. All right. Thanks, Ann. I don't know where Dr. Young went. All right. All right. Let's see. We're on here. All right. I got it. I'm on. I don't know where she went. Okay. So I can't see the questions. BNP. Wait, hold on. Oh, look, here's the chat. Okay. Her battery probably died. Yeah, maybe. Just died.
Are you guys still getting me? All right, we're still going. Okay, you can get it too. Oh, you are getting stuff. Hey guys.
I figured it out. Okay, now we're all here.
All right. My computer just died. It had battery. So all right. Yeah, I'll pull this. We'll do this way. Better way in your room anyway.
Good.
What?
You're back.
It came back. Cool. I'll go fix that. I guess I'll meet you back there in a second. You can keep talking. My handle.
Okay. We're really good at this. Modern technology. Yeah, right. All right. Let's see. Let's get back on track. BNP is brain natriuretic peptide. So that is a marker of, historically a marker of congestive heart failure. So more significant damage to the heart itself, less within the vessels itself.
Hi.
You there? You there? You good?
Yep.
You plugged in?
I had a half a battery left. I don't know, man. It's Mercury in retrograde.
I don't know, man. We're flying high.
Yeah. So, did we talked about pro-BNT?
So I just mentioned a marker of congestive heart failure. In cases essentially of any more than your sort of run-of-the-mill, my cholesterol is a little high, it's something that we can screen for. So I'd say it's on my sort of like second tier list for cases where there's a little more complication, especially within the heart, the organ itself, as opposed to just accumulation of atherosclerosis in the vessels. But yeah, something that we can think about screening for sure. Mm-hmm.
Yeah, I usually think of it if I'm concerned about just cardiac function beyond just like the blood vessels themselves. I didn't realize. So I got to see what you're seeing on your screen. You can see you can be distracted by all these questions too and stuff. It's great,
I figured out how to pull it up.
I love feeling connected to my buddies and everyone out in the community. This is a fun way to do that. And I mean, this is the longest we've gotten to be able to talk to each other in a long time. How do triglycerides work? You want to do that one?
How do triglycerides work anyway? I think the thing I'll say about triglycerides is, we talk about like overall cardiovascular disease, cardiovascular risk. And when we're talking about that as a big picture, we're talking about blood sugar also, right? We're talking about a diabetes assessment, figuring out what kind of blood sugar regulation someone has. And that's important because if there's too much sugar in the body, that's inflammatory. That's very inflammatory, right? The reason diabetes is so devastating is that so much sugar in the bloodstream is profoundly inflammatory and causes damage in all the vessels. So the relationship with triglycerides of all the, yes, all the cholesterol levels are modified by diet, but specifically the link between blood sugar and cholesterol, I think of as triglyceride, where if someone has a diet that's higher in sugar, starches, carbohydrates, refined starches, we're going to see higher levels of triglycerides and higher levels of blood sugar. And when we see one come down, we often see the other come down. Yes, of course, there's cases of, genetically elevated triglycerides, and there's other ways that we can intervene in helping to reduce it. But I think of it as a sort of a connection, a carryover between the blood sugar world and the cholesterol cardiovascular world.
Yeah, I mean, essentially, so for people so when we say a lipid panel, right, you've got your total lipids, your good cholesterol, your HDL, your bad cholesterol, your LDL, and then your triglycerides. And triglycerides are basically essentially another way. All of these are how we move fat through our blood vessels to take a big, broad scope picture of it all, right? This is how we are going to mobilize. We can either put them on a low density lipoprotein, a high density lipoprotein, or the triglycerides that are passing through. The reason you have to fast when you get blood work done is mainly for the triglycerides, because if you eat a meal, your triglycerides are going to go up. And so yes, when your liver sees, a lot of sugar, it's going to increase LDL production, and it's also going to translate into higher triglycerides. That's part of the connection with sugar and your lipids is this connection between, if you have diabetes and high blood sugar, you're going to be more at risk for these lipids to oxidize and become plaque, essentially. So there's actually guidelines that we get as physicians to be monitoring people who have high blood sugar levels, that we have to get their cholesterol. We really have to monitor that even more closely than someone who doesn't have high blood sugar.
Definitely. Right.
Does that work yeah, it works, right?
Triglyceride primer, pretty good.
Yeah. So the take-home message is essentially, I've had a lot of people who are told you're fine at your physical, and when we do further testing, we're actually very concerned about their cardiovascular status because of the calcium score, because of an LPA, because of inflammation, because of oxidative stress. And so those are all things that are not being brought up at a physical that you should consider looking at. Inflammation, oxidative stress, all these other things, plaque production, because if those aren't being looked at, then we're not actually getting a picture of your wellness. Like we said, it's like half of people who have heart attacks have normal cholesterol levels. So it's only a piece of the picture for sure. Right.
The take home is get more information. Mm-hmm. Before you get too caught up. I mean, and then the other thing I'll say is that people ask me all the time, how come cardiologists don't do this? How come cardiologists don't run these tests? How come cardiologists don't run these calcium scores? I mean, some do, and there some are moving in that direction. But honestly, and tell me if you think I'm wrong, but if you're going to give everyone a statin anyway, it makes less of a difference. The details make less of a difference. I think that's true.
Here's the thing. How many people are in their 30s that have cardiologists? Unless you have a cardiac condition, you're not going to the cardiologist for prevention. And one of the things I would say is there's a couple local cardiologists who've shared with me, they're like, we love getting your patients because they're already doing a lot of the prevention stuff and they're already on top of it. So I think one of the things is that, you're right. Unfortunately, conventional medicine doesn't have the tool set that we do, and we're very spoiled with our tool set. And then I think also part of it is that at that point they're doing damage control in a lot of cases. They're in the throes of people already having massive amounts of plaque and major issues, where they're in that mode, not in prevention mode. They're in damage control mode.
Right. That's fair. That's definitely true. And the thing is with that 30-year-old with a high risk, maybe there are some cases sometimes, but putting someone at 32 on a lifelong protocol of high-dose Lipitor is going to get their cholesterol or LDL down, yes, but I mean, there's some other concerns there too.
At what cost, for sure. Yeah, right. I totally agree. And the truth is, it's not addressing the cause. I think treating the cause, one of our major tenets is to look at what is driving heart disease or a cardiovascular disease in a person. And it oftentimes is not elevated cholesterol. I think that's the take home message. Even if we should make sure we're watching lipids, it's not driving the inflammation. It's not driving oxidative stress. Lipids don't cause oxidative stress. Lipids don't cause inflammation. They are damaged by those things and creating the issues. So I think the bigger picture is we should be screening for those. To circle back on what inflammation markers we look at, The main one, cardiac CRP or regular CRP. For people with other things going on, you can look at autoimmune markers like ANA, or you can look at a SED rate, which is also known as an ESR. Ferritin levels that are very elevated can be a reflection of what's going on inflammatory wise. And I think when we talk about these tests, these are all conventional tests that are run through labs that are locally run. And so I think that's another myth around functional medicine and the stuff that we do, is that there's going to be this like large, ticket item coming, like this massive expensive lab test going along with these tests. And we see most people, it either gets covered by insurance or a max out of pocket of like $40, right? It's not a massive expense for people.
Yeah, it is. It's affordable. It's accessible. I mean, I literally can't think of a good reason if you carry some risk to not get a snapshot of where it is. And we typically, I'll run a wider panel the first time to get a sense, and then the things we have to track, we track over time, so we're not drawing buckets of blood all the time. But for people who have that elevated family history or individual history, getting that information, I think that can just be such a life-saving endeavor.
Yep, absolutely. We'll open up for another minute of questions, and then we'll probably wrap it up for tonight, guys. Thank you so much for everybody coming and chatting about heart health. Certainly talk to your doctor about checking out some of these other tests and being really proactive on your cardiovascular health. Do you have any other take-home things that you like for analogies, or I think I used up all mine. I thought it was going to be novel with the ping pong ball versus the sand, and we're on the same page once again. I'm
sure I'll think of something when I get off.
Yeah, of course, right? Well, thank you guys for bearing with our technology and going through this with all of us. This was really fun, and for those who couldn't make it, we are going to save this and we'll probably put it back up on our website or on our YouTube channel. So thanks again for making the time for us, and we will be certainly putting other topics out there. If there's something you want to hear about, certainly message our Facebook, and we will put something together. We love doing these, so thanks again.
Yeah, take care, everyone. Be well, and treat your hearts with a lot of love, huh?
Good job. Nice little catchphrase at the end. All right, thanks, guys. We'll talk to you soon. Take care.